Well, welcome back, and I'm delighted that Professor Robert Clancy has come back to join us. Welcome, Robert, and thank you for coming back.
Pleasure.
It would be quicker to say what qualifications Robert doesn't have, but let's just say he's a retired professor of pathology, emeritus, consultant physician, doctor of science, and holder of the Order of Australia. That'll do to be going on with. So we're delighted to join us on the channel. Now, I've been thinking, Robert, and that's always a bit dangerous to do in isolation for me. At the start of this pandemic, the World Health Organization was saying that it's absolutely vital to vaccinate poorer countries, because it's when we vaccinate poorer countries that we will stop new variants arriving. This idea that it's not over for anyone till it's over for all of us. But I've been thinking, I think that if the virus is spreading in an unvaccinated population, that's less likely to generate new variants. And if the virus is spreading in a highly vaccinated population, that's actually more likely to generate new variants, and could explain partly why we're seeing so many new variants in Western countries. Is that right, wrong, or partly right?
I think that's probably right, John. It's interesting to go back and look at the idea of essentially evolution and selection. That most people watching this will understand that we've had antibiotics now for a generation, and that progressively a new antibiotic is found, and it's fantastic. Penicillin basically killed every staphylococcus initially. Then all of a sudden we're finding we're getting a resistance. And the idea of evolutionary selection was introduced to understand this change. And essentially what happens with antibiotics is that it kills those particular bacteria that are susceptible to, say, the penicillin, but there'll be some that have had mutations that allow a resistance to that. And once you take away the susceptible bugs, then it changes the balance. And biology is all about balance. It's interesting, if you go way back in history, all the ideas about biology and medicine have at some stage been about balance and control. And this is what happens if you take out of the population the susceptible, then it gives an advantage to those that were otherwise suppressed or kept in small numbers. And then you find that dominant species becomes the resistant species. And exactly the same can occur with vaccines. And what is important about the vaccines for COVID and for flu is that the vaccines are not sterilising vaccines. If you have a vaccine that will completely eliminate a bug, then it's not a question of resistance coming about, because you've essentially taken out all of those bugs at the beginning. But if you have a vaccine against the respiratory tract virus infections, you don't do that. You actually suppress. You don't prevent the transmission from one person to another, because you're stimulating only immunity in the bloodstream, not at the mucosal sites where the virus will multiply, and from there it'll be presented to the community. And so you've got a much greater chance of having a selected resistant virus. And so it makes a lot of sense that vaccination in populations, which often get to 80–90% of a population, are likely to favour the evolution of a resistant bug, a resistant virus. And a lot of people believe this is exactly what has happened. For example, particularly in the Omicron series, which is what has been around since the beginning of 22, late 21. Does that make sense?
It does. So if someone's vaccinated, they'll have antibodies, and the virus which is able to reproduce in that individual would be by definition one which is not sterilised by those antibodies, and that will be the one that reproduces. So it's the one that survives that reproduces and becomes
Remember
more
that the
prevalent.
antibodies we're talking about are antibodies in the blood, and they will be valuable when the virus is trying to get into that blood phase, into the gas exchange apparatus of the lungs. Those antibodies will have basically no impact on what's going on in the mucosal surfaces of the body, which is going to determine the transmission. And so, in a sense, it's very different to say something like measles or viruses that have to go through the bloodstream to establish standard clinical disease.
Yeah. That didn't quite click before. So there's this fundamental difference between systemic viruses and respiratory mucosal viruses. Two different different modalities of evolution.
Yes, they are fundamentally different.
Way back, when there was claims that the COVID vaccines, for example, would prevent transmission, because the COVID vaccines work systemically and not in the mucosal compartment, there was no way they were ever going to stop transmission.
No, right from the beginning. And those who, I think, understand the difference between compartments of immunity were fully aware of this, that it would be very unlikely that you would change that transmission.
And of course, we're not here to accuse anyone, but you would expect the scientists in big pharmaceutical industries to be aware of this, what is really a very basic aspect of immunology. But we can't comment on that. It's basic,
but I think, yeah, I mean, it's a bit like the advertisement about oils aren't oils. You know, you can be an immunologist looking at mice that you become world expert on how this... I mean, immunology is a very broad area, and I've experienced that a lot of people who are very competent immunologists in their area are not totally familiar with the dynamic of compartmentalized immunology.
That's true, but I would expect a team of immunologists to have some smattering of expertise between them. So I think you've been very generous to them there, Robert. But we'll leave that there because we simply don't know that. But it makes perfect sense to me that the vaccines...
Looked at it in my own country. Yeah.
Yeah. So, sorry, say again,
the people who are making decisions... the people who are making decisions are very often public health doctors, respiratory physicians, and, you know, in fairness, they do not have depths of understanding of immunology. I was amazed at the beginning of the pandemic in Australia, talking to my colleagues in clinical immunology. I'm a clinical immunologist, and none of them were being asked for their thoughts and opinions. And it became very quickly public health and political decisions as to how the pandemic would be controlled.
You know, if I wanted a brick wall built, I'd get in a bricklayer. If I wanted my pipes fixed, I would get in a plumber. Why on earth didn't governments get in immunologists that actually know about this? In retrospect, it really does look somewhat bizarre. Yeah. But that's now history, I guess.
I don't know the answer.
So if we carry on producing vaccines that are specific to new variants, for example, the vaccine that's being used now for the autumn booster program is part original Wuhan virus and part BA.4/5 antigen-derived viruses. That could be part of the reason why we no longer have BA.4/5 very much, at least in the United States, and it's well on the way out in the UK and is being replaced by other variants, because it's actually, the vaccine is actually an evolutionary pressure against the proliferation of the viruses that the vaccine is acting against.
Yes, that's true. Obviously it's extremely complicated, but we now have something like 2-4% of the isolates are reflected in the content of the current dual combination viral vaccines, the messenger RNA vaccines. And there's essentially no protection if you look at straight antibody, protective antibody, neutralising antibody activities against the current isolates, which are running at I think the XBB 1.5, something like 60, 70, 80% in our communities.
It's probably heading
extraordinary thing.
It's heading higher than that as well.
Yeah.
Yeah. So
well, I'm just thinking back to when Omicron itself came at the end of 2021. Gee, I'm really showing my age.
End of 2021. Yeah.
That within a month, it was the dominant species. I think it came out of Africa and then it arrived in America, and within a month or so it became the dominant species extraordinarily quickly.
Yeah.
And it was, an environment where there was this heavy immunisation, 80, 90% in many areas, immunised people. So it's not, you're not being an Einstein by saying, well,
no.
To what extent did that high level of irrelevant immunity allow the emergence of the Omicron species, which actually has turned out to be highly infective, but not nearly as damaging as the earlier one, which is how a pandemic usually evolves.
Absolutely. So we're getting very high rates of reinfection in the UK, in the States, and Australia, I guess, at the moment with these new variants. Whereas in countries with lower levels of vaccination, for example, African countries where you might only have 20% of vaccination, the reports I'm getting from the ground there is that they're not testing very much, but clinically they're not getting any COVID at all, as in they're seeing zero. So I saw a wonderful video a few days ago that we played on the channel, where my friend in Africa was going into the COVID and Ebola isolation unit, and it was empty, completely, utterly empty, and yet we're still getting the reinfections. So if we have systemic immunity because of injection, sorry,
yeah, in Australia, I just saw the reports. I live in New South Wales, and I think a week or two ago, essentially every hospitalised patient with COVID were immunised, most of them with boosters. So we have to ask questions, and as you know, one of my repeated points has been the importance of spacing vaccines. All we're doing is driving to suppression and probably facilitating the emergence of new isolates.
The new isolates, the new variants. So this, just clarify this in my mind, that the systemic immunity, to the extent you get that from a vaccine, that's going to stop me hopefully getting sick to the extent that it does, but it's not going to get into the... It's a different sort of immunity, isn't it, in the mucosal compartment?
Yes, my take on this is that early on, when we were getting invasive disease, where the Wuhan isolates and the A's and the B's, they were getting into the gas exchange apparatus where you start recruiting systemic immunity. You move from the mucosal to the systemic space. And if you had antibodies against the virus when it got there, it was quite effective. And that's led to the recognition that the early vaccines were preventing serious disease, evidenced by going to hospital or dying, or going into intensive care requiring intubation. But as the disease has changed, a number of things have happened. One is we're getting less virulent virus, so it's not getting to the gas exchange apparatus, and so what antibody you've got is relatively irrelevant, if you like, to the outcome. And the second is that we're getting less correlation between the antibodies made from the currently used vaccine and the virus that's infecting. So you have a variety of variables leading to a situation. And the third issue is that by repeated vaccination, we're actually and this is well demonstrated, we're turning off the immune response. So we have a number of variables occurring, which is asking questions about where we go with vaccines. And this is irrelevant to whether we're talking about genetic vaccines or talking about traditional antigen vaccines.
So constantly revaccinating is going to stimulate these T suppressor cells, which are actually going to reduce the immune response.
Yes, the example I think we might have discussed before is that if you go to the doctor and say, I'm getting lots of allergies, you're inhaling pollens, which is exactly the same in a sense as inhaling the virus. He said, oh, I'll give you a series of shots. And he gives you immunisation by injecting the pollen, or it's injecting the virus, and you turn off that immune response by doing this. And that's exactly what we're now finding with repeated, poorly thought through strategies of vaccination.
It's so obvious when you say it like that. It makes perfect sense. So I think what we're saying, Robert, with the early vaccinations, which we were protecting against severe illness and death, that because they were systemic, the antibodies in the immune cells would be stimulated. They were then going to the alveoli in the bottom of the lungs, which are really part of the internal organs, part of the systemic circulation. So when the virus went down into the respiratory tract, when the virus arrived in the alveoli, there were antibodies and sensitized T cells way down in these alveoli waiting for the virus. And the antibodies combating that virus would prevent the acute respiratory distress syndrome. Is that roughly what we're thinking?
Yes, that in principle is exactly what was intended and in fact occurred. And those, in fact, as a result of knowing this, special antibodies called monoclonal antibodies, which are very, very concentrated against only the particular virus, were developed as treatment and quite effective treatment. But that treatment only worked as long as the antibody was relevant to the particular variant of virus that was around. And now, of course, we find those antibodies, which were effective a year or two ago, are not effective against Omicron. Well, for two reasons. One is the Omicron variant has moved away from the specificity of the antibodies used in treatment. And secondly, the Omicron variant is actually not getting into that systemic compartment where the gases exchange. Oxygen goes into blood and carbon dioxide comes out. And so I notice around the world now, people have moved away from using the monoclonal antibodies because they don't work very well.
No, and of course it's brilliant that the Omicron is not getting down into the systemic areas and into the alveoli. So that's basically these monoclonal antibodies were a form of passive immunity, Robert, were they?
Yes, exactly. It was exactly the same as way back in 1900, the Germans and French were making antibodies in horses and injecting them into young people with pneumonia, and it was probably saving 30-40% of the people from dying. And that was called passive immunity, as opposed to injecting the ground-up organism, the virus or the bacteria, as Pasteur and others did, and that would create antibodies being made in the body, and that was called active immunity.
Mm-hmm. Well, I'm old enough to remember being given injections of gamma globulin when I was going into areas with hepatitis A and B prior to the availability, as I'm sure you do.
Somewhere between the horse. The problem with using the horse antibodies is the body would make an immune response against the horse antibody and get what was called serum sickness. Some people got very sick from making an It's a bit like it's a hypersensitivity response that occurred, and then we went from the horse to, if you like, human antibodies, which is the one you're talking about in hepatitis, to the monoclonal antibodies, where we get the mouse to make a very, very specific antibody, and we very cleverly make it so similar to the human, we call it humanized monoclonal antibody. So we've got a spectrum. We haven't gone a long way from the horse in 1900 to the monoclonal antibody.
Yeah. So one of the other things I want to talk about now, Robert, that's need clarification in my mind anyway, this idea of viral recombination and the difference between point mutations and recombinant new variants.
Right. When you multiply the RNA, which is the genetic information of the virus, when that multiplies, about every 10,000 multiplications, one of the sausages in the sequence of genes changes colour. It's a different sausage. And so you get a different protein produced from the genetic information. And that's called a point mutation. And that occurs whatever. Now, in sophisticated cells, for example, human cells, we have very sophisticated repair mechanisms that are looking for these mutations, and they will repair and go back to what you should have. Very clever. Whereas the virus has a limited amount of genetic information. Its aim is to keep making lots of virus and surviving. And so it has very limited repair mechanisms. And so when you get a point mutation, it becomes expressed in the virus. Now, it may be a lethal mutation for the virus, and so the virus stops. You stop there. But at the moment, there's something like 300 point mutations in the Omicron series alone that are being studied by the human genetics laboratories. So this is, lots of these are occurring. They only become important and relevant when you get a survival advantage and a different clinical outcome from that particular mutation. And that might be only one in hundreds or thousands. So it's occurring all the time. And again, there's the selection pressures we talked about. Now, occasionally, and this is very well understood in flu virus, you get one cell infected by two slightly different viruses. And there you've got a confusion of genetic information. And instead of just one sausage in the sequence, whole groups of sausages get exchanged. You get chunks of the genetic information exchanging between each other. And that will give a much bigger change in the virus that survives. So this is called recombination. This is genetic recombination. And it's been known and exploited experimentally in a whole range of circumstances. It occurs in the way in which we develop the genetic information from the mother and the father in what's called meiosis, where you actually develop the baby embryo to get slightly, you don't want to be exactly the same as your mum and dad, and that this exchange of information occurs within the it's true.
You get more like
and
yourself
so
as you get older.
It's a well-known mechanism. Yeah, and it's almost certainly occurred in some of the Omicron sequences. So you get a big jump. So the chance of antibodies from the earlier sequence, the experience you may have had from either having the virus as an infection or from the injection, is much less likely to be relevant to protection because you've got a big change in the virus. And we know this. Let's go back to flu. We know in the 50s and the 60s, we went, go way back further to 1918-19 when we had the so-called H1N1 flu virus. And that persisted through to, I think, 56, when we had the pandemic in the 50s and then the pandemic in the 60s. These pandemics in, I think it was 1956, 1968, every 12 years, were due to recombination events. So instead of the point mutation, which we see now, and that's why we adjust our flu vaccine every year very subtly, it was a big jump. And so suddenly we have a pandemic because the natural immunity that had been developing with H1N1 over 30, 40 years was much less relevant to this new big jump genetic virus. And exactly the same thing seems to have occurred with the current XBB 1.5 variant, which is 1.5. Is that what I said? The XBB.
Yeah, well, we got there between us. XBB.
That seems
XBB 1.5.
Yeah, that's right.
Yeah. Apparently, that's a derivative of two BA2 sublineages that recombined. So it's almost like a form of sexual reproduction, almost for viruses, isn't it?
Oh yes. It's a basic biological process. There's nothing unique about it.
So two viruses infect the same cell. The RNA intermingles somehow and ends up as a new.
Yeah, and chunks of it, big lump here goes there, and you're still covering the same outcome proteins. It's just that you're doing it a little differently, and they're a bit different. They still may work. A lot of them, of course, will be lethal changes, and you'll never see or hear that clinically. It's only the one that becomes selected out that becomes a problem.
But you only need one, really, because if that one has a massive survival advantage, as XBB 1.5 does, then that's the one that's going to go from one person basically to the whole world. Yeah.
And if it's very infective but not particularly serious in terms of the disease it causes, then in many ways it's showing you the transition out of a pandemic towards an endemic situation where every season this or minor variants of that will play until all of a sudden you get another big change and it does become more serious, and we never know when that might occur.
Mm-hmm. It's really quite amazing that one change in the RNA basis, one change in the 4-RNA basis can change one of the amino acids, which can change a whole protein, which can change the whole way that the virus behaves. It really is quite an amazing sort of cascade just from one single mutational change that can potentially happen.
Yes, it depends, of course, where in that protein that amino acid occurs. If it's a very important part for the activity of that protein, then it's important. If it's just one of the if you like, the junky bits, like the handle of the protein, it may not be important. Or it may be very important for the virus to survive, and it will be deleted, gone.
But by definition, the ones that we come to see that become prevalent are the ones that do have the survival advantage. Otherwise we wouldn't see it. If they died off, we wouldn't see it.
No, that's right. That's true, and that's of course what we're seeing. It's played out exactly as you would predict it to play out with respect to the COVID pandemic. What we don't know is the extent to which intervention with vaccines has changed for the better or for the worse the evolution of the sequencing.
So just to clarify, of the single point mutations, that's genetic drift. The virus will gradually drift. If there's recombination,
these are terms out of influenza.
Chunky changes, that's genetic shift. And the genetic shift, as we've seen with the XBB 1.5, now
would be a shift.
We would get massive immune escape because of the shift. And we're very fortunate.
Which means, of course, that the previous vaccines are basically going to be pretty useless.
Yeah. And we're just very fortunate that so far these drifting and shifting has resulted in increased transmissibility, which you could argue is a good thing because it's going to increase natural immunity. We're very. Are we just? Is it just pure good luck? Is it just pure good luck, Robert, that none of these new variants have been more pathogenic?
Well, when you think about it, the virus wants to survive. It's irrelevant to the virus whether it kills the host. It's giving a IQ to the virus it doesn't possibly deserve. But there's no advantage to the virus actually killing you or me. And so a perfect adaptation of a virus is where you get high transmission rates without actually removing the host that's required for the virus to multiply and persist. And so, and that has become a basis of way people think biologically. However, of course, things can go wrong, as we well know. And this will particularly occur with big shifts like you get with recombinant RNA.
Mm-hmm. Robert, fascinating as always. Great insight into the nature of viral evolution and the really quite significant clinical implications of that. We've seen this has caused pandemics and all sorts, and great implications for vaccination. Just one last question. Is the next pandemic probably going to occur as a result of a genetic shift in some existing virus? Or do you think it's more likely there's going to be emergence of a novel zoonotic virus that we haven't come across before?
Of course, nobody knows. I think my involvement over many years as an immunologist involved in infection control, the country, Australia, would have a program waiting for the next pandemic, which we all expected to be influenza, because influenza had established that pattern. We trained to expect a pandemic in influenza. So when a coronavirus, which we were quite used to seeing as mild upper respiratory tract infections, suddenly became a pandemic, it changed the scene. Now, whether we now see a different pattern of coronavirus, COVID variants, if you like, Omicron variants and whatever is the next, occurring as a seasonal infection, and then every now and again undergoing point or recombinant mutations, so that you get a more vicious and a more invasive virus. We don't know. We now have to look for that, just as we have for influenza viruses over the last 20, 30 years. So no one can predict what's going to happen. We have these very nasty viruses occurring, like Ebola and a number of others in Africa, and we just go back through history and see that yellow fever, for example, which no one thinks about these days except when they have to have a vaccine, came out of Africa, and it devastated the eastern states of America. People would leave the cities in summer to get away from the mosquitoes that were causing yellow fever. So the world is characterised by pandemics, epidemics that come and go, but they certainly do keep coming, and they will keep coming, and we need to be prepared.
Absolutely. Sobering thought and wise words of preparation. Professor Clancy, as always, we could talk all night. Infinitely fascinating for your insights. Thank you very much. We really appreciate it. And that's reflected in the amount of people watching these videos. They're very popular. So thank you once again.
Thank you.